Good afternoon, everybody. It is a privilege for me to be with you at this 20th Biennial Congress of the South African Society of Nuclear Medicine. I would like to thank Dr. Stuart Moore and the organizing committee for giving me the opportunity to address you today. In the next 15 minutes, I will talk about the status of nuclear medicine. And my apologies, I was trying to do the presentation live, but due to some technical issues, it was not possible. That is why I'm sending the recorded presentation. So most of the data that will be presented was included in this article, The Development of Nuclear Medicine in Africa, that was published in the Clinical and Translational Imaging Journal in 2022. Two colleagues from South Africa, Dr. Mike Sateke and Dr. Marisa Foster, contributed to this article. That also had the support of Dr. Salah Abu Youssef from Africa. We all know that nuclear medicine and molecular imaging have grown tremendously in the last 50 years across the world. And collectively, it has played an important role in the elaboration and implementation of management strategies for prioritized public health issues. This is something that is very important because it was not the case in the past. Nuclear medicine was not in the public health arena. Nowadays is more and more considered as part of the health technology assessment and plans of different countries. How about the status on the African continent? Yes, there has been a growth, but mainly in the last 2 decades. However, like in many other regions, the availability of equipment is very heterogeneous, and there is a scarcity of human resources. So which are the major drivers of growth in nuclear medicine? In my opinion, the main driver has been the technological developments. We have witnessed the development of PET-CT, PET-MR, SPECT-CT that for sure have propelled the applications of nuclear medicine. But if we also take into consideration the increase in the burden of disease, in particular non-communicable diseases, where nuclear medicine has an important role. So this has been also something that has somehow contributed to the development of nuclear medicine. Aging population, of course, for population that is elder population, they will have more non-communicable diseases, and the role of nuclear medicine then also will be more important. The trend of having a personalized medicine. For sure, nuclear medicine is the main medical imaging technology for the personalized medicine, to be able to provide the personalized medicine approach. I don't have to mention that. I mean, the advancements in clinical research and drug development are tremendous. We have seen the development of several radiopharmaceuticals for both therapeutic and diagnostic purposes. Very important, the increasing the awareness of the importance, the capabilities, and what nuclear medicine has to offer to the patients. So it is important, this one, and we have to continue increasing this awareness, not only among the medical imaging community, but also we have to do it in the public health arena. And there is more investment in health. Locally, nuclear medicine and in particular PET has been included in these healthcare investments. Most probably many of you are familiar with the IAEA Imagine database, which is a medical imaging and nuclear medicine global resource database that contain information on the status of the CT, MRI, PET, and SPECT scanners, and also on the availability of human resources. Most of the data presented in this publication and used for the article that I just mentioned has come from Imagine. So let's see a snapshot of the status of nuclear medicine in Africa. 29 countries out of the 54 countries, meaning 54%, have nuclear medicine available. Most of the centers were installed between 2014 and 2019. This was the case for 17 countries. Unfortunately, there is a huge disparity in access. while South Africa and the North African nations have access to SPECT and PET. Most of the sub-Saharan African countries, they either don't have or they have very limited access. How about the SPECT? The SPECT started in Africa in the late 70s and early 80s, and again, mainly in South Africa and the North African countries. And really, nuclear medicine began to mature in the African continent in the early 90s. And this happened when numerous independent departments were established in various hospitals across Africa. In total, we have 301 gamma cameras in the continent, but they are serving 1.3 billion people, so we are not doing very well. 18% of these are hybrid, and one of the 54 countries has only a radioimmunoassay. They don't have nuclear medicine, but only RIA. There are 14 countries that are doing either feasibility studies or are planning to start the nuclear medicine facility in the near future. The development of nuclear medicine in Africa has been strongly linked to the support provided by the IAEA. 44 out of the 54 countries have had or currently have technical cooperation projects that are aiming at technology, transfer, and capacity building. As I mentioned before, nuclear medicine became in Africa started to grow in the 70s, 80s, and 90s. And one of the things is that they became an independent specialty. In Algeria, nuclear medicine became independent specialty in 1981, and in South Africa in 1987. Some countries, they still have formal links with other specialty, which is the case of Egypt, where nuclear medicine is very linked to radiology, or in Morocco and Tunisia, where it's linked to the biophysics. 5 countries in the continent have nuclear medicine postgraduate programs, and 22 started training of nuclear medicine physicians abroad in around 2000. 17 of these countries started after 2004. So again, 2000, 2004. So this is the snapshot of the current status of nuclear medicine in Africa regarding the availability of gamma cameras. The map that you can see on the right-hand side is the one that is included in the publication of the status of nuclear medicine, and the data that is included in the table has in 3 of the countries 2 different numbers. The one on the left with the higher number is the one that is included in Imagine in 2023, and the one in brackets was the one that was included in the publication. So let's see. Egypt is the country that has the highest number of SPECT. They have 99 scanners, followed by South Africa with 86. Then Algeria, Morocco, Tunisia, Sudan, Namibia. But when you see the availability of scanners per million inhabitants, then you can notice that the highest number of scanners per million actually is in Namibia with 2.4, followed by South Africa with 1.4, Tunisia 1.3, Mauritius 1.6. It is important to consider the number of scanners per million inhabitants, and even more, it is essential to try to evaluate the prevalence of non-communicable diseases and the availability of scanners. Well, let's see the global scenario of the availability of SPECT and also PET scanners per million inhabitants. The highest number of PET and SPECT scanners per million inhabitants is in North America and Europe with 18 SPECT scanners per million inhabitants. Remember our previous slides when we were saying that in Namibia we have 2.4? The average in the high-income countries is 18 per million inhabitants. And for the PET scanner, they have 3.2. This is followed by Australia. I'm going to stop 1 second my video because I cannot really see the numbers, but my apologies for that. Then Latin America with 3.6 SPECT scanners per million and zero point 0.5 PET scanners, followed by North Africa, where we have 1.7 and zero point 0.5. South Africa, the southern part of Africa is much less. Then in Asia and the Pacific, we have also India and the STAN countries. And this is the current status in Africa. You see North Africa, 1.7 scanners per million inhabitants and zero point 0.5 PET scanners, and in the rest of Africa, 0.1 and 0.01 PET scanners. Let's see the status of PET scanners in the region. Only 7 out of the 54 countries in the African continent have PET scanners available. So we have South Africa with 21 scanners, 0.3 per million, Egypt with 18, Morocco, Tunisia, Libya, Algeria, and Kenya. So those are the only countries that have PET scanners. At present, there are several countries that are working towards acquiring the first PET-CT scanner with the support of the agency. In this case, we have Nigeria, Senegal, and many other countries that hopefully will be able to provide PET services to their patients very soon. Globally, according to the per capita income, in the 30 low-income countries, where about 700 million people live, a SPECT scanner serves approximately 33 million people. And a PET scan serves more than 250 million people. So I will show this data here on my screen. I don't know if you can see my mouse right now, but this is in the high income country, one PET scanner serves 250,000 people. The same scanner in the low income country serves 250 million people, not thousands, millions. As for the SPECT scanners, one scanner for 57,000 people, more or less, in the low-income countries, while the same scanner in the low-income country is for 33 million people. Let's compare this with other imaging modalities. Let's see, for instance, the case of the MRI or the CT. We have the same. One scanner, one MRI serves 36,000 people in the high income, and the same scanner serves more or less 5.1 million people in the low income. One CT for 25,000 in the high income, one CT for every 1.6 million. So the inequities or the disparities in access is really something that has to be corrected. Data about the availability of CT and MRI in the region. So you can see, for instance, in the northern Africa, there are only 6.2 MRIs per million inhabitants and 11.3 CT scanners also per million inhabitants. And if you compare this, look, sub-Saharan Africa has very little. Let's compare with Latin America, for instance, how the access in Latin America is the 7.7 scanners, MRI scanner per million inhabitants and 15 CT scanners, while in Africa, even this is the one with the highest number of equipment, is really very low. More data about the availability of CT scanners per million inhabitants, and again, Algeria, Tunisia, Libya, Morocco, Mauritania. They are the countries that have the highest number of scanners, not only PET, SPECT, but also CT and MRI. So there are many things that we need to do in order to make the access a little bit more equal. MRI scanners, very similar to the two previous graphs. How about human resources? We have in here the map of the human resources for radiology and for nuclear medicine, and is color coded. In Africa, look, the availability of radiology and nuclear medicine physicians is very, very limited. It's less than the rest of the world. And as you can see, I mean, when you compare, there are more or less one nuclear physician for every 10 radiologists. In Africa, not really. I mean, we have very limited number of radiologists, but nuclear medicine physician even less. And again, the South Africa and the Northern African countries are the ones that have the better um, access or more professionals available. This is the map of the nuclear medicine physicians in Africa. Of course, the countries that have the highest number of equipment are the countries that have the highest number of physicians available. We have South Africa with 65, Algeria with 110, Kenya, then for instance Morocco with 65, Tunisia with 60. So always there is a growth, there is a room for improvement. There is a room for improvement of the on the availability of professionals well qualified. And as I mentioned before, locally there are already some countries that have started their own training programs in nuclear medicine, and many more that are considering the implementation with the support of the IAEA. The number of equipment per se, they really do not constitute like a good indicator of the status of the health. It is important to consider other aspects, as I mentioned before. We need to see the epidemiology, the demographics, the catchment area that the equipment will cover. This will help us to evaluate or the priorities in the needs, to see the gaps, to see the considering the budgetary restrictions, we can prioritize on the needs. So let's take a glimpse of the epidemiology of, in particular, non-communicable diseases. Let's see that. So this graph in here represents the main causes of mortality from 2000 to 2019. 73% globally of the cause of mortality are due to non-communicable diseases. And as I mentioned at the beginning, nuclear medicine play an essential role for the management of non-communicable diseases or patients with non-communicable diseases. 19%, which is this area in blue, are deaths attributable to communicable diseases, maternal, perinatal, and nutrition, and 80% injuries. Out of these 73%, 44% of these diseases are mainly cardiovascular diseases or deaths due to cardiovascular diseases. 22% cancer, 19% other diseases. But let's see the specific case in Africa. Remember this number, 73%. Let's go to Africa. Okay, some more data here. So how many people die yearly due to non-communicable diseases, premature deaths, which is less than 70 years of age. 41 million people around the world died on a yearly basis due to non-communicable diseases. Now let's go to Africa. Remember this number, 73%? You see, 61%. So my apologies. I'm not talking about Africa yet. I'm talking about something different, and is the going back to the previous one, 71% of mortality between 2000 to 2019. Then in 2020, the mortality due to non-communicable diseases decreased to 61%. But why? Oh, make a wild guess. What happened in 2020? Of course, COVID happened. So the 18% of the mortality due to non-communicable diseases increased to 31%. So it's not that we really have a reduction in the mortality due to non-communicable diseases, but rather the mortality due to COVID increased tremendously. And this data was published by the WHO and is what they call the global excess mortality due to COVID between 2020 to 2021. So we have the recorded number of deaths, but when we see the total number of deaths that were attributed to COVID, not only direct but indirect, is 14, almost 15 million people. So that's why the mortality in here increased. Now let's go to Africa. Remember the 73% for the between 2000 to 2010? This is Africa, 54% for the same period, 2000 to 2019. Of course, COVID didn't happen. They didn't help, and the mortality due to communicable diseases, infectious diseases, it was even higher, though it was already 18%. Out of the 54% of the mortality due to non-communicable diseases, interestingly, cardiovascular diseases, 38%, very similar to the global, but cancer only comes third after the other non-communicable diseases. So this data is very important for you in the context of your country, your center, your city, to keep this data updated, because this is the data that you can use in order to justify the need of a new department or a new gamma camera. The role of medical imaging is clear. We play a role around from screening to palliation in the management of all the cancer patients, screening, early diagnosis, disease location and spread, prognosis, but we go beyond the visible. We can help in the selection of the appropriate therapy, in the evaluation of the therapy response, in the providing personalized medicine. And something that is extremely important, we have come to a fork few years ago already, in which we can really define if we are going to continue talking about the lesion detectability and the spatial resolution, or we change our mindset and we talk about precision medicine. This is the road definitely to theranostics. Here, nuclear medicine has a very, very important role to play. Now, let me talk a little bit about the IAEA. As you know, the IAEA is an independent, intergovernmental science and technology-based organization within the United Nations system, and we serve as the global focal point for nuclear cooperation worldwide. Our role in the division of human health and in the nuclear medicine and diagnostic imaging section of subprogram, which is the section that I lead, is to provide comprehensive support to establish or strengthen the practice of radiology and nuclear medicine in a context of appropriate use, safe, and quality of clinical practice. We work in cooperation with other colleagues. At the beginning of my talk, I mentioned that nuclear medicine is definitely a multidisciplinary approach, and the IAEA addresses nuclear medicine as a multidisciplinary specialty. So we have the colleagues from the dosimetry and medical physics that they support all the medical physics aspects of nuclear medicine, quality control, quality assurance, dosimetry. We have the colleagues from the radioisotope products and radiation technology. They provide all the support for the radiopharmaceuticals, good manufacturing practices, development of new tracers, establishment of new cyclotrons. And then we also have the radiation protection of patients unit that support in all the issues that are related to radiation safety and radiation protection. The nuclear medicine, we provide support across the entire spectrum of nuclear medicine, starting from scratch. When you do not have a nuclear medicine department in the country, or you need a new nuclear medicine department, a new gamma camera, a new PET, we can help you to put together the case, to make the case of the need. We can help you in the planning and setting up of the right department adequate to the right demographic. We can help in the training of the professionals for the continued professional development, on the appropriate use criteria, on the application of safety standards, not only radiation protection, but also the international pharmacopoeia, in the implementation of quality management systems like the Quantum program, and of course, clinical research. We are very much engaged in the development and encouraging our low and middle income countries to be part of well-coordinated research projects. Just to give you a glimpse, from 2012 to 2022, 129 fellows from Africa were trained. And here there is the list of countries that received training from the IAA. The highest number was Mauritania, Gabon, Benin, Zimbabwe, and they went mainly to other African countries, and the host countries were South Africa, Morocco, Algeria, Tunisia, the same countries that we mentioned before that have the highest number of equipment, professionals, and they also have nuclear medicine programs. Well, to conclude, I just want to mention that the IAEA has more than 50 years of support of nuclear medicine. We have been helping the African countries to build sustainable capacities in the use of radiation medicine that include radiology and nuclear medicine, providing education and training of the multidisciplinary team of professionals. Over the past years, we have helped at least 28 African countries to start the first nuclear medicine department, and we continue to do enormous efforts to increase the access to nuclear medicine. Our vision is to improve the clinical practice of radiology and nuclear medicine and provide quality of good quality of services. I thank you very much for your attention, and I want to conclude by mentioning that at the IAEA we are very much focused on making nuclear medicine available, accessible, appropriate, and affordable. And I thank you very much again and for the invitation, and I look forward to seeing you next time in South Africa. Bye.